Hi everyone, welcome back to Allied Health 209. Now, just a little housekeeping. We discussed chapter 5 and how long it was. And so, because I'm trying to get y'all the maximum amount of time to be able to go over these PowerPoint presentations so that you can fill out your review guides that are located in your black binder and then start studying this material so you can start locking it in your mind. Okay, because like I told you guys, the best way to learn this material and really get it in your mind and understand it is to read the chapter in your textbook, to watch these PowerPoint presentations, have your black binder open to the chapter, and then fill out the answers in review guide, study your review guide, okay? Because this, along with all the discussions we have in lab, all the things that we go over in lab, what we're doing is taking the things that we learn in lecture, putting them together with the things that we learn in lab, and being able to piece it all together. So we're going to go through these slides because this is a lot of information quickly so that you guys will have plenty of time to study this chapter, because this will be our last test on the chapter. Now, as you guys looked at your tentative course calendar, you will notice that you are finishing up this week. You'll finish up taking test 4, which is on chapter 5 in hematology. The quiz 4 on immunology and microbiology will be up soon for lab. That's those little short 10-point quizzes. That one will be up this week, any day now. And so once you take test 4 on chapter 5, then what you want to do is put a line through it and flip over to on your tentative course calendar to test 5 on chapter 6 and 7. Circle it because that's the next thing we're going to be doing. Okay, so test number 5 is again on 6 and 7, which is chemistry and immunology. And then you will not have a test 6, okay? Test 6 will be on chapter 8, microbiology. We're not going to have an individual test for chapter 8. I will put up the PowerPoint presentations on chapter 8. We'll cover some things in lab, but you will not take a test 6 that is just on chapter 8. But you need to watch the PowerPoint presentations on chapter 8 when they go up. You need to fill out the review guides and study it, because there will be questions on your comprehensive lecture final dealing with chapter 8 on microbiology. Okay, so let's jump right into it. And remember, if you have any questions on microbiology chapter 8 or how all these things are going to go out, if there's any confusion out there, you know you guys can text me, call me, email me, or talk to me in lab, and I'll be glad to answer any questions. So this will be when we take test number 5, which is on chapter 6 and 7. That will be our last regular test, okay? But then again, I will put up the PowerPoint presentations on chapter 8 on microbiology, and you are responsible for that material. But you won't have an individual test for that, but there will be questions on your comprehensive lecture final covered on chapter 8. So let's get started. As always, in anything, we always want to have goals and objectives, right? And so these are our learning objectives. They're also listed in your textbook, and they're important because they tell you guys that at the end of this, once you read the chapter in your textbook, you watch these PowerPoint presentations, fill out your review guides and study them, these are the things you will know and understand. Everything from identifying, describing, and telling the significance of the clinical components of plasma, all the way down to identifying and informing the physician when lab reports show chemistry values that are out of range. And you know these are things that we're also discussing and going over in lab. And like I said, I'm going to move through these relatively quickly, so let's get started. We always start with our key terms, which you know are going to be on the test, right? And you have to understand the language, be able to speak the medical language, understand the medical language, to be able to understand what's going on, and to be able to speak intelligently with your coworkers. So let's start with these key terms. Okay, I'm going to go through these quickly because these are just the key terms that you guys are going to be responsible for knowing for Chapter 6. Okay, so I'm not going to sit here and read each one of these out to you, but I'm going to methodically go through them so that you guys will have them. You will have the key term, the definition, and you can start studying and learning them. So make sure you pause these and use these as a study tool to see if you're getting these answers right. So pause this one now and see if you're answering these questions correctly. Okay, like I said, guys, y'all can watch these more than once if you want. You can use those key term slides as a way to study and test yourself. Okay, let's get started. Chapter 6 is on chemistry. We're talking about the fundamental concepts of clinical chemistry. And this is a broad overview, right? Because you're going to take the stuff we learn in lab, the stuff we learn here in lecture, reading your textbook, and we're going to put it all together to make a complete picture of this, right? So chemistry tests detect and measure chemicals found in the plasma and other body fluids. Most chemistry tests in ambulatory settings use plasma and or urine. Here's a little flow chart. We can also see this in some very good pictures and illustrations, a lot of great information in your textbook to go along with this. Where we're talking about the basic makeup, right? So when we look at plasma up at the top, right, and it goes down, we show our proteins, and there's our proteins, okay? And then we have clotting proteins, and then proteins that hold water, and then we have our antibodies, and then over to the other side, we know that plasma is 90% water, right? Then it has some salt and electrolytes, some nutrients like glucose and amino acids. It has waste like uric acid and creatinine. It also contains hormones and enzymes and all these things. So this gives you a picture of showing you the breakdown of what our plasma is made up of. So now let's look at reference laboratory specimens. Okay, we talked about this in lab, and we know that in a lot of smaller labs or physician's office labs, or even in some bigger physician's office labs, if they're within, like, let's say, for instance, the Willis-Knighton Health System, right? They may draw specimens there in their lab, and they may do some CLIA wave laboratory testing there inside their lab, but there may be a lot of their specimens that they send off to one of the bigger labs inside the Willis-Knighton system, and they may have a courier that comes, a laboratory assistant or someone that comes once a day, every day to pick up the chemistry samples to take them over to the larger lab to run tests that are more complex testing that cannot be done in a small lab. Okay, so let's talk about the type of specimens that are usually collected and sent to the reference lab. So most of the time, okay, and again, this is going to depend on the policies and procedures of your particular laboratory or your particular facility, and you always want to follow them, okay? Because there could be some differences. Some reference labs may want a red top, right? With the serum tubes that clot, you know. And remember, an additive is any substance that's added to an empty tube. The glass red top tube has no additives, right? No additives at all. If I asked you what additives were in a plain red top tube, you would say none. Now the plastic red top tube has silica. That's that white fine powder we see that coats the inside of the tube, and that's just in there to speed up the clotting process. But remember, an additive that speeds up the clotting of a blood specimen is called a clot activator, right? Because we're talking about turnaround time. We need this tube to fully clot before we can spin it down, right? So we want that tube to clot as fast as we can. So that's why we have a clot activator such as silica placed in the plastic red top tube, right? The SST tube The SST tubes are the serum separator tubes, right? They also clot and contain silica that speeds up the clotting process, but they also have gel that's down in the bottom. And when they're fully clotted and we spin them down in the centrifuge, that gel moves up and forms a barrier between our serum and our cells. Green top tubes are used for panels. The green top tube is favored because of stats, because you do not have to wait on the green top tube to clot, so you can spin it down immediately, take your plasma off, and run your chemistry tests on that. Okay? We know heparin is the anticoagulant that's in the green top tube. And remember, heparin is an additive. Remember, anything that's in a tube is an additive. Gray top tubes for glucose tests because they have a preservative, right? Sodium fluoride. They usually also have potassium oxalate in them, or they can have EDTA in them. So a lot of those, not only do they have a preservative that preserves the glucose in the tube, so of course they're the thing you want to use best in glucoses, but they also have an anticoagulant in them most of the time, which means you do not have to wait on them to clot. So you can spin them down, so it helps with your turnaround time. And remember, any of those words you see in blue up there are going to be key terms. These are terms you need to learn these terms, okay? So here's one of our thinking sides. So I want you to pause this one immediately. Use this as a way to test yourself to see if you're getting these questions right. Okay, guys, please use those thinking slides as a way to test yourself. So still we're talking about reference laboratory specimens. So how long should tubes without anticoagulant be allowed to clot prior to centrifuging them? It depends on the tube. The glass red top tubes can take up to 30 minutes, maybe even up to 60 minutes to clot. So you know you're going to have to wait at least 30 minutes, and it may take longer than that. Plastic red top tubes and SST tubes, they take anywhere from 5 to 15 minutes. Remember, plastic red top tubes and SST tubes clot faster because they have silica in them, which is a clot activator. Red or gold micro containers, those little small tubes that we use to collect blood, usually from a finger stick, they only take about a minute to a minute and a half to clot. So how long should a tube be spun in the centrifuge prior to separating the serum into another tube? We need to centrifuge our tubes for about 10 to 15 minutes. And make note, all tubes should be filled at least 50% full, except the light blue top tube and the purple top tube, which needs to be 100% full. Guys, this information right here is information that you will need to use regularly as a lab assistant, a medical assistant, or a phlebotomist. And you need to make sure you lock this information into your mind. And the best way to do that is to go over it and over it and over it. So here's one of our case studies, and this is a way for you to take the things that you learn in lecture and the things you learn in lab, put them together to test yourself to see if you're faced with a situation out in your clinicals or out working as a lab assistant or medical assistant, you'll be able to handle these issues with your patients. So pause these case study slides, read through them, and see if you're getting the right answer. So go ahead and pause it now. Okay, we're still talking about reference laboratory specimens. You always want to refer to the reference laboratory requisition for proper tube requirements. You will have a policy and procedure in your physician's office lab or in any laboratory that tells you what paperwork you fill out, what are all the requirements for your tubes to be sent off to a reference lab. You want to be familiar with those and follow them to a T. Some specimens may need to be refrigerated. Some should not be spun down and separated from the serum or the plasma, and various panels are available for ordering groups of tests. So, physician's office lab specimens for CLIA wave chemistry test. What type of specimen is usually used for the CLIA wave chemistry test performed in a physician's office lab? Most of the time we're looking at capillary blood from skin puncture, and it's collected into various testing devices. Okay, that's the most common. You may have a specific, and you guys have done some of these things in lab, where you would collect them in microhematocrit tubes, so you can do a CLIA waved hematocrit test. You will collect it into a glucose machine like an AccuCheck or something like that, that type of instrumentation where you can get your patient's glucose results immediately. You have hemoglobin tests. There's different kinds of tests, and most of them use a special machine with a special collection device that usually uses blood from a finger stick. There's also cases where whole blood in anticoagulated tubes as recommended by the test method. A lot of times you will get a green top tube for lipid profiles, a gray top tube for glucose, and a lavender top tube for hemoglobin A1Cs. So what happens during the digestion of carbohydrates? Let's talk about glucose metabolism and testing dealing with glucose metabolism. So let's remember, carbohydrates, once we eat them, our body breaks them down into sugar, okay? And then that sugar enters our bloodstream. From the bloodstream, glucose enters the tissue with the help of insulin and is stored there and used later for energy. So you think you eat something high in carbs, your body breaks it down to sugar, it's flowing around in your bloodstream, but we want to keep homeostasis, right? So then our insulin comes out and moves that insulin into our muscle tissues and into our liver so that we can store it for when we need it later. So what happens when excess glucose is taken in? So excessive glucose is stored in the liver and the muscles as glycogen, okay? And it is combined with fatty acids to produce triglycerides and is stored in fat or adipose tissue, okay? So this is a case where you're eating more than you're burning. When we talk about weight loss, it's not as simple as calories in and calories out, but it's pretty close. You want to make sure that you are burning the same or burning more than you're taking in. So if you're at a good, healthy weight, okay, then you need to know your resting metabolic rate. Let's just say that you're a healthy young person and at rest, doing nothing, just sitting around in a chair, you burn 1,400 calories in a 24-hour period. Now, this is just numbers I'm making up. You would have to have yours tested to know what your resting metabolic rate is. And the more muscle mass you have, the higher your resting metabolic rate is, okay? So the more muscle you have, the more calories you burn at rest, okay? So let's just say it's 1,400, right? And let's just say you're not a very active person. You don't exercise a lot, you don't walk a lot, you don't run a lot, you do a job where you're sitting down a lot. And when you get off work, you're tired, you go home, you sit on the couch, and then you go to bed, okay? And let's just say you don't burn a whole lot extra calories. So you're not burning hundreds of calories. Because remember, guys, you can run a mile and you only burn 100 calories running a mile, approximately, okay? So then let's just say at the end of a 24-hour period, you burned an extra 300 calories in just walking and getting up and sitting down, right? You burn, so that's 14 plus 3, that's 1,700 calories that you burned in a 24-hour period. But let's just say you ate McDonald's for breakfast, Sonic for lunch, and McDonald's for dinner. And you took in 4,000 or 3,000 calories in that day, which is not hard to do if you're eating fast food a lot. You can see where you're bringing in a lot more calories, a lot more sugar than you are burning in a day. So your body has to do something with it. It doesn't want it floating around out in your bloodstream, right? And there's only so much space in your muscle tissue, especially if you don't have a lot of muscle tissue, and there's not a lot of space in your liver. It can only store so much in the form of glycogen. So once it has packed the liver full of glycogen and packed your muscles full of glycogen, then what it does with the rest of the glucose that's left around is it combines it with a fatty acid to produce triglycerides, and then they store it as fat in your adipose tissue, and that's how we gain weight, right? So remember, you want to know that the storage form of glucose is called glycogen. Glycogen is stored in your muscle tissue and in your liver. Okay, here's one of your concepts. You want to be able to describe in your own words why people gain weight when they eat too many carbohydrates. I want to make sure you guys understand this, not only for your own health and the health of your children, your family, and your loved ones, but if you're a medical assistant and you're out there taking care of patients, you need to understand this process, okay? Because that's what's going on. That's why we need to teach our patients that weight training and building muscles helps us with our glucose, right? Because we have more muscle tissue for us to be able to store glycogen, right? So that when we do then decide to go for a long walk or decide to go for a jog or decide to do anything that needs energy, go play soccer, ride a bicycle, jump rope, then our body goes to those stored glycogen, brings it out, and uses it as fuel when we need it, right? So remember, calories in and calories out. So be able to describe this in your own words. Remember, carbohydrates are broken down into glucose. In the body, excess glucose is stored as fat. So we're still on glucose metabolism. So what are the roles of the hormones insulin and glucagon that are produced by the aisles of Langerhans in the pancreas? So insulin lowers the blood sugar, right? So we eat a big meal, okay? Blood gets in our bloodstream. Insulin comes out to help move the glucose from our bloodstream into our tissues, right? Now, let's just say, we've been really being careful about the amount of calories we take in, and we eat a good, healthy breakfast, but it's not real high in calories, and we eat a good, healthy lunch, and it's not really high in calories, and then we get off work, and we decide to go out and do a little jog with our friends, and our body goes, hey, we need some glucose for this, so glucagon will come out, that hormone will be released out into the blood, and it tells you to, hey, let's bring some of this glucose that we have stored in our liver and our muscles out, and we need to use it for energy because we don't have enough glucose right now, right? So remember, they're antagonists, or they work against each other. One makes us take sugar out of our bloodstream and store it in the tissues, and the other one makes us take it out of the tissues and bring it back into the bloodstream so we can use it for energy, okay? Remember, glucagon when glucose is gone. Here's one of our thinking slides, so pause this one right now and make sure you're putting this all together. Okay, we're not in the classroom right now, thanks COVID, but you can do this, right? You can do these learning activities. Okay, so I want you guys to if we would have been in class to do this little activity, it just would have been a fun way for you to understand that it's like a tug of war between the insulin and the glucagon, right? So you need to understand what would happen to the sugar level in the body if the insulin was winning, okay? So you think they're tugging back and forth, right? And insulin's getting more of theirs in, then we know our glucose levels are going to do what? They're going to go down, right? Because the insulin is the hormone that tells our body to take the take the glucose out of our bloodstream and store it in the tissues, right? If glucagon was winning, then our blood glucose level would go up because it tells us, hey, we need sugar, so let's remove it out of the tissues and put it back in the bloodstream. Here's another one of our ways that you guys learn to take a concept and be able to describe it in your own words why hormones, insulin and glucagon, are considered antagonists. Guys, the reason you want to be able to do stuff like this is because as a professional, whether you're a lab assistant or a medical assistant, and you're out there working with other nurses and doctors, you want to be able to articulate things in your own words and be able to explain them to patients and to be able to speak intelligently with doctors and coworkers. So make sure that your answer contains stuff like this, that your antagonist is something that works in the opposite way from something else. So insulin lowers blood sugar levels and glucagon raises blood sugar levels. So how does glucagon from the alpha cells of the pancreas increase glucose? It's by converting glycogen to glucose, by converting non-carbohydrates, proteins, and fats into glucose. Okay? Because if it gets real low and you don't have enough stored glycogen, let's just say those people who run marathons or do Ironmans, and they're out there working really hard for hours and hours, they may go through all the stored glycogen they have. And if they're not taking in any more glucose, then it's going to take those non-carbohydrates, things like your proteins and your fats, and turn them into glucose so they can be used as fuel. So how does insulin from the beta cells of the pancreas reduce the plasma glucose? By moving glucose into all tissue cells, storing excess glucose as glycogen in the liver and the muscles, and then storing excess glucose as triglycerides in adipose tissue or fat cells. What must the glucose levels in the bloodstream be maintained to keep the body in homeostasis? Because remember, that's the objective, is to keep our blood glucose levels in the blood, just in the blood, at a certain milligram per deciliter, so we know this is a safe, balanced way, right? And it needs to be between 70 and 110 milligrams per deciliter. So what is the reference value for fasting glucose test? Again, 70 to 110 milligrams per deciliter. If you haven't ate all night and you wake up that morning, you should still have a glucose level between 70 and 110, because even though you didn't take in food during the night, your hormone should have risen and told your body that it needed sugar, and it would have broken either protein and fats down into glucose to use as fuel, or would have taken the ones that were stored in your liver and muscles to use, or your liver to use as fuel, to keep your blood sugar at that constant level. So again, here's one of those higher learning thinking activities that you guys can use as a way to see if you're putting all the stuff in lab and lecture together. So pause this one, read through it, and see if you're getting the right answer. So just remember, glycogen is the storage form, right? It's where the insulin told it to take it out of our bloodstream and store it in the liver or the muscles to use later. And glucagon is the hormone that is released that tells us that our blood sugar is low and it's gone, right? We don't have enough glucose and we need to bring it out of the storage areas or convert protein and fat into a glucose that we can use for fuel. So why is all this important? Because of diabetes mellitus, right? It is a disorder of carbohydrate metabolism characterized by hyperglycemia, glucosuria, which is sugar in the urine, and a faulty or no insulin production. So that's why we're worried about all this, because of the high rate of obesity, the issues with diabetes mellitus that we face as a nation, including heart disease. All these things wrap around each other, and these are the chronic diseases that are killing Americans today. And as medical assistants, this is what we're going to see a lot of when we're out there working, right? Okay, so let's get into depth about diabetes mellitus. Okay, we have type 1 and type 2. Okay, type 1 or insulin-dependent diabetes mellitus. This is the one that usually shows up at a younger age. It's usually before the age of 30, and a lot of times it can be in a young adult, teenager, 20-year-old, 18, 12. You can see it at that age, anywhere in those ages, okay? It's an abrupt, rapid onset of the symptoms, okay? In this case, they have little or no insulin production. They're usually either normal body weight or thin. They have issues of ketoacidosis occurring often, polyuria and the rest, and it's usually treated with insulin. And make sure you understand all these words in blue, because these are some key terms that you need to know and understand. They will show up on a test. So with diabetes mellitus type 1, this is really an autoimmune issue, okay? It's the autoimmune destruction of the pancreatic beta cells, which prevents insulin production, okay? You must receive insulin by injection or pump or some other way, they unfortunately cannot control this with diet alone, okay? It is the more severe of the type diabetes because, again, this is not something they can just change a lifestyle habit with to fix it, right? They run into other issues that can lead to hypertension, heart attack, and stroke. The coating of the small blood vessels with sugar because they have to be spot on with checking their glucose levels and getting their insulin as quickly as they can. Because the coating of those small blood vessels with that sugar creates an issue of poor circulation to the extremities and can eventually cause not enough blood flow and oxygen to fingers and toes. Gangrene can set in, and it usually can lead to you having your toes or foot cut off, maybe the leg, below the knee amputation. It's very serious. That's why we have to really keep up with your glucose levels, your diet. Not that it can be controlled by diet, but you do want to keep an eye on your diet as well. Eat a healthy diet. Watch processed foods and lots of added sugar, but also to make sure you're getting your insulin at the appropriate amounts and times. It can lead to, of course, kidney disease, which can lead to renal failure. It can cause retinopathy, which can lead to blindness. Ketoacidosis from the breakdown of fats for energy, which can cause a diabetic coma. So, individuals with insulin-dependent diabetes mellitus must monitor their blood glucose levels, as I said, several times a day to keep the levels down, okay? Diet, although they cannot change, they're not going to be able to reverse type 1 diabetes with their diet. But their diet is vitally important, okay? And you need to stick to a whole food, plant-based diet with little to no processed food and not a lot of excess sugar. You need to exercise and maintain a strong, healthy cardiovascular system and make sure you're administering your insulin properly. Okay, now let's move on to type 2 diabetes, which used to be referred to as adult onset diabetes, but unfortunately now it is occurring in children. So over the past, I would say 10 years, we've just seen a steady decline. We've had an increase in obesity in children, and this poor diet, a lot of increased sugar with sodas and processed food has led to a drastic increase in obesity and type 2 diabetes. Now, it says it usually occurs after the age of 30, and that is true, but we are seeing signs of this in younger children. It's a gradual onset, and sometimes it can be asymptomatic at first. Insulin is usually being produced and present, but you can get to the point where the insulin is just not working anymore. It's like you're insulin resistant. 85% of the people with type 2 diabetes are obese. Ketoacidosis seldom occurs. You have the rest of the polyuria and the rest sometimes, but it can be reversed and treated with diet. They do have oral hypoglycemic or insulin sometimes given to them. So sometimes they will get on medicine temporarily and then try to lose weight, fix their diet, start to exercise, and get healthier. And once they do that, sometimes they can come off that medicine and reverse the type 2 diabetes. Type 2 or non-insulin dependent diabetes is directly correlated to your lifestyle, okay? It's the impaired glucose tolerance, which the beta cells have periodic release of insulin resulting in episodes of hypoglycemia and hyperglycemia, and insulin resistance is the inability of insulin to move glucose into the body cells. Non-insulin dependent, usually controlled by diet. It is one of the less severe, especially if caught early and you do something about it. Here's the deal with this. It can also lead to atherosclerosis, hypertension, heart attack, and stroke. It can lead to kidney failure. It can lead to, like I said, toes cut off, feet cut off. But the deal is, it's a lifestyle issue. It's your diet, it's exercise, okay? We need to reduce the amount of stress in our life as much as we can. Get a good 7 to 8 hours of sleep at night. We need to cut out all the excess sugar. That means all the drinking of these large Polar Pop sodas and eating a lot of this processed food that we just put into the microwave. We need to switch to a more whole food, plant-based diet. We need to exercise regularly. We need to make sure we're getting in 10 to 12,000 steps a day, get a good night's sleep. And if you can do these things, you can start to reverse this condition and lower the chances of you developing hypertension, having a heart attack or a stroke, having kidney failure, or having to have a toe cut off. So guys, these are our higher learning activities. So make sure you pause them, read through it, and see if you're answering appropriately. Because what we're trying to do is see if the things you're learning in both lab and lecture, you're able to put together so that when you face these scenarios with patients in your clinical rotations or as you're working as a medical assistant, you will be able to understand this stuff and help your patients. So pause it now. Okay. Now, let's talk about pre-diabetes, okay? This is that stage where you've been eating poorly, you haven't been moving, you're leading a very sedentary life. The job that you lead, it makes you sit behind a desk all day long. When you get off work, you're stressed out from your job. You feel like you don't have time to cook, so you drive through a window and pick your food up through a window, and you go home and eat, and then you sit down on the couch and try to de-stress and watch TV before you go to bed. You're not exercising, you're not moving at all during the day, and your diet is poor. So this is the beginning of that, and this is how we start with pre-diabetes. So when blood glucose levels are above normal, but not high enough to be considered diabetic, okay? That is when we start noticing pre-diabetes. When you go into your doctor and you go in month after month or every year for your physical, and you steadily, the weight is still going up and up, and your glucose levels will just keep being a little bit above normal every time. This is signs that you are developing pre-diabetes, and we want to get on this immediately because these individuals are at risk of becoming type 2 diabetic. They can delay the development of diabetes through modest weight loss, a diet low in refined carbohydrates, and regular exercise. This is literally how we can help these people. And if we can get them to understand this, and we can get them to understand that adopting an exercise routine, trying to get in 10 to 12,000 steps a day, trying to take their health and very seriously, switching to a mainly plants, right? Whole foods, right? Diet, where you are decreasing those sugary drinks and sugary beverages and getting the weight off to stop yourself from going to becoming a type 2 diabetic, which can then lead to heart attack, stroke, hypertension, renal failure, right? So what is gestational diabetes? Diabetes that occurs during pregnancy, right? The mother has excessive weight gain and her baby weighs 9 pounds or more. Symptoms subside after delivery, but the mother is prone to type 2 diabetes later in life. Now, this doesn't absolutely mean that she is going to get diabetes later in life. As a matter of fact, if you were a little bit overweight when you got pregnant, and then you really gained a lot of weight when you were pregnant and developed gestational diabetes, this should be a warning sign to you that there's things in your lifestyle that you need to change. So after you have your baby, you might want to look at making sure you get that weight off, getting out there and exercising, trying to get good 7 to 8 hours of sleep at night, drink plenty of water, switch to a whole food plant-based diet so that you will decrease the possibilities of you developing diabetes later on. So now, transient diabetes. That's temporary diabetes occurring during an acute illness, or if you're on some type of long-term steroid therapy for something, it could cause you to have diabetes, but that's just a temporary situation linked to the illness or the therapy. So fasting blood glucose, FBG, right? Blood sample is taken after a 10 to 14 hour fast, usually most of that during the night when you're sleeping. Diabetes greater than 126 milligrams per deciliter. So you are diagnosed as a diabetic if your fasting glucose level, you truly fasted properly, right, for 10 to 14 hours, and your blood glucose level is greater than 126 milligrams per deciliter, then you are diagnosed as a diabetic. If it's between 100 and 126 on 2 separate days, then you can be diagnosed with prediabetes. Oral glucose tolerance test, or the 2-hour postprandial test, postprandial meaning after eating, starts with measurement of fasting blood glucose as above. Then the patient drinks or eats glucose-rich drink or a meal, and blood samples taken 2 hours later. Patient is retested for blood glucose level, which must be down to 140 milligrams per deciliter. If it's greater than 200 after 2 hours, then you can be diagnosed as a diabetic. If at 2 hours it's still between 140 and 200, then you can be diagnosed as a pre-diabetic. Now, this is important because we want to catch these people before they become full-blown diabetics, because it is easier to get them to lose the weight and exercise and change their diet to prevent this from happening. Random glucose test, right? That's a specimen collected any time of the day or night. If that specimen is above 200 milligrams per deciliter, they can diagnose you as diabetic, although they would probably run some other tests just to make sure. And if you ran 140 to 200, they could diagnose you as pre-diabetic. But again, they may actually run some other tests just to solidify this. But most likely, if you're running 200 milligrams per deciliter just on any random glucose, you most likely are a diabetic or right there at it. So the GTT, the glucose tolerance test, it begins with fasting blood and urine specimen taken and tested, right? Then the patient drinks a glucose-rich beverage. Specimens are collected and tested at the half hour after drinking it, and every hour for 2 to 6 hours. Specimen times are calculated from when the patient finishes drinking the glucose-rich beverage. 200 or greater at or after 2 hours would signal you having diabetes. You want to watch your patient for signs of fainting and or nausea during this test. So here's another one of our case studies. So you guys pause this and see if you're able to put the things you learn in lab and lecture together to be able to handle this clinical situation in the field. So go ahead and pause it now. Guys, make sure you go through these test results and make sure you understand what's the results you're going to see that's going to tell you they are diabetic or they are a pre-diabetic. Okay, so we're still talking about blood glucose screening and monitoring tests, right? So what is glycolated? I never can say that word right. So during the lifespan of an RBC, whenever blood glucose levels are high, the excess glucose clings to the RBC's hemoglobin molecule, right? Making it permanently glycolated or sugared, right? So in other words, and you'll see in this picture, there's a red cell, right? And you see the little red hemoglobin, round hemoglobin molecules, right? So when this glucose is just constantly excessive in the bloodstream, those glucose molecules will almost like bind to the hemoglobin, okay? And you have glycohemoglobin, and it's just sugar. They just sugars them, right? So the percentage of glycolated hemoglobin is directly related to the levels of blood glucose during the past 2 to 3 months, right? Because about 120 days is the average lifespan of the RBC. So the more it's done like that, the higher that glycolated level is. That means that the longer those hemoglobin molecules were exposed to excessive amounts of glucose in the bloodstream. Remember, this is the tattletale test. This can tell a doctor not just what your glucose is today, because maybe you did real good over the last 2 days and you didn't eat cake or pie or drink a Polar Pop of Coke, right? You did real good for a day or two because you knew you had to go in for your doctor's appointment, and when you did your glucose result, you wanted it to be in range, right? Well, that you can get away with, but this hemoglobin A1C test is going to tell that doctor what your glucose has been running over the last 120 days, around 2 to 3 months. And he's going to see where, yeah, you may just have did real well with your diet the last 2 days, but the last 2 months has not looked good. And again, that glycosylated hemoglobin test, hemoglobin A1C, it measures that percentage of glycosylated hemoglobin and provides an accurate long-term index of the patient's average blood glucose levels over time, or the life of an RBC, which is anywhere between 180 and 120 days. Okay, reference range for non-diabetics. If you are not a diabetic, then your hemoglobin A1C should run anywhere between 2.2 to 4.4%. If you are an out of control diabetic, then you are running between 6% to 8%. Not only are you a diabetic, but in control. You are diabetic, but you are in control. So at the top, those are the numbers, those are reference ranges for a non-diabetic. Someone who has not been diagnosed with diabetes and is not a diabetic, 2.2 to 4.4%. If you're a diabetic, but you have your diabetes under control, between 6% to 8%. Okay, here's another one of our case studies. Pause this one and see if you're getting it right. Guys, I hope you're using those case studies and higher thinking slides as a way for you to test to see if you're learning this, because you should have read the chapter in your textbook before you started watching the PowerPoint presentation. And as you're watching this, you're going to see how much of this you're actually absorbing, right? Because we have to go over things and over things to lock them in our mind. So, and remember, I want you guys to be able to articulate things in your own words. So I want you to be able to describe in your own words why the hemoglobin A1C test is called the tattletale test. So, rates of obesity and heart disease are increasing in the United States. We know that heart disease is the #1 killer around the world, right? Lipid screening and monitoring are now recommended and approved as CLIA waived tests. So now we're going to move on to lipid metabolism and testing for lipids, okay? And these are the tests: diabetes mellitus, heart disease. These are obesity. These are these things that are killing people the most, right? So these are the things that we want to have, these CLIA waived tests that these physicians can do inside their physician's office lab, so they can immediately diagnose problems with their patients, to be able to monitor the treatment they're giving their patients, and to be able to treat them and get their cholesterol down under control, their triglycerides under control, keep their glucose in check, right? Because we know that these things like high cholesterol, high triglycerides, obesity, out of control diabetics, all lead to heart disease, all lead to heart attacks, strokes, right? So we want to name those 2 commonly tested in the lab, right? And those big ones are cholesterol and triglycerides, right? So what happens to fats during digestion, okay? So we eat something that's fatty, right? Fats are broken down into fatty acids. In the liver, fatty acids are reassembled into a variety of lipids that serve several essential functions. So you don't want to eat a no-fat diet, no fat made as fat, okay? You want to have a balanced diet that has some healthy fat in your diet, okay? Because fats produce steroidal hormones, which we need, right? They transport fat-soluble vitamins. They maintain body temperature and healthy skin. They protect vital organs and nerves. They serve as an energy source when glucose is not available, and they satisfy the feelings of hunger. So make sure you guys, and make sure that you know this for your patients, you want to have healthy. Now, it needs to be, you need to keep an eye on how much of that it is, but you need to have a small percentage of your overall diet intake needs to be healthy fats. Okay, so where does cholesterol come from? We have endogenous cholesterol and exogenous cholesterol, right? Endogenous cholesterol is manufactured in the liver. Exogenous cholesterol is obtained from food sources. Okay, so make sure you know the difference. One is manufactured, N-E-N, manufactured in liver, E-X, food, right? Food sources. So saturated fats come from meat, eggs, and dairy and raise your cholesterol. That's why you want a mainly plant-based diet, right? With minimal meat and eggs and dairy. Trans fats comes from man-made hydrogenized margarines and oils, and they also raise cholesterol. Monosaturated and polyunsaturated fats are liquid at room temperature and lower cholesterol. So that's why I talked about healthy fats, like even things like avocado, coconut oil, olive oil. But even with that, they can't contain a lot of calories, right? Oils, fat contains a lot of calories, even the healthy fats. So you want to make sure you're watching that calorie in, calorie out, right? So monosaturated fats include, like I said, olive, there's canola oil, omega-3 oils. Polyunsaturated fats include soybean, sunflower, and corn oils, which are all from vegetables, right? Then fats that produce a high cholesterol level cause atherosclerosis, okay? And you see that picture, there's one picture over to the far left is a healthy vein or artery that is clean on the inside, and then we see the buildup that starts to be in there, and that's how we can have blocked arteries. It can lead to heart attacks and strokes. So what is lipoprotein? The liver binds lipids such as cholesterol and triglycerides to proteins so that the lipids, which are not able to mix with water and plasma, can be transported in the bloodstream, which is approximately 90% water. We know if we have water, right, and we drop some oil in it, that oil will not mix with that water, right? It floats on top. So for us to be able to move cholesterol and triglycerides from one place to the other in our bloodstream, which we know is 90% water, right? Our liver has to bind it to a protein so that it can then move through the bloodstream. So lipoproteins equals lipids plus proteins. So we have three categories of lipoproteins, okay? We have high-density lipoproteins, HDL, which is good or healthy cholesterol because they remove plaque from the arteries, right? Then we have low-density lipoproteins, LDL, bad, right? Or lousy cholesterol because they form fatty plaque on the walls of the arteries. And then we have very low-density lipoproteins, which is very lousy, right? Triglycerides, right? So a study tip to help you: high grades are good, low grades are bad, and very low grades are very bad. So make sure you're understanding your three different lipoproteins, which one is bad and which one is very bad. So what laboratory values is the best predictive indicator of the possible future myocardial infarction? So what test can we do that's going to tell us that we're at the highest risk of having a heart attack at some point, right? So total cholesterol divided by the HDL value, okay? A ratio under 4.5 indicates that most of the total cholesterol is made up of good HDL. A ratio above 4.5 indicates that not enough HDL is being made. So total cholesterol divided by HDL. That is the biggest possible indicator to tell you whether in the future you're at a risk of having a heart attack. A ratio under 4.5 should be the patient's goal, okay? Anything above 4.5 is just red light going off saying I'm at a risk of having a myocardial infarction. So here's another one of our case studies. So you guys pause this one now, read through it, and see if you're putting this together. Okay, so still talking about lipoprotein. So what are some ways to increase HDL levels and lower LDL levels? Because as a medical assistant, or even for your own health, for the health of your spouse, your children, these are some things that you know you need to put into place to cut down the chances of having a future heart attack, right, or stroke. Exercise. I know a lot of people don't like to exercise, but find something that you like to do, because exercise is vital. It not only helps your mental health, it is loads of research out there proving it improves your mental health and it improves your physical health. It lowers the risk of obesity, diabetes, heart disease, and stroke. It also helps you sleep better at night, which you need to get a good 7 to 8 hours of sleep a night. A diet with good polyunsaturated and monounsaturated fats, diet with good carbohydrates, whole grains, and high fiber, and cholesterol-lowering medications if prescribed, like statins. What we hope is you can be on the medicine temporarily until the exercise and the change in diet can get you to a place where you may no longer need them. Now, there are some people, due to genetic issues, that may always have to have them. But the last thing you want to do is make that situation worse by not eating a healthy, whole food, plant-based diet and exercising. So let's talk about triglycerides. So triglycerides account for 95% of the fat stored in the adipose tissue. It's transported in the blood plasma as LDL and VLDL. The direct results of diets high in carbohydrates, especially sweets and alcohol. That's why you jokingly see the stereotypical gentleman that drinks too much beer has the belly in the front. That's because people who eat a lot of sweets like cakes and pies and ice cream and drink a lot of beer or alcohol, okay, these are this unhealthy carbohydrates, and they tend to accumulate in the adipose tissue around your waist. So how should the patient be instructed prior to triglyceride testing? Because you are the one that may be instructing this patient on what they need to do before they come back into the physician's office to have their triglyceride tested. The patient must fast for 12 to 14 hours and have no alcohol for 48 hours prior to testing. What does the plasma look like with hyperlipidemia from a high triglyceride level? It can have an opaque white appearance. So the lipid panel. You want to be able to list the tests in a lipid panel and their reference ranges, okay? We got first, these are the tests: total cholesterol, HDL, LDL, triglycerides, and then your TC/HDL ratio. Those are the tests that are on a lipid panel. Now we know TC, or total cholesterol, right? It needs to be less than 200 milligrams per deciliter. Okay, we know HDL, which is the high density lipoprotein, needs to be greater than 40 milligrams per deciliter. Our LDL, or low density lipoprotein, needs to be less than 100 milligrams per deciliter, less than 150 milligrams per deciliter for triglycerides, and less than 4.5 or lower, right? For our total cholesterol divided by our HDL, which is that ratio. And we understand that that TC-HDL ratio is the key point we're looking at to be able to tell us if we are at a high risk for a future heart attack, right? So analysis of the lipid panel determines cardiac risk, right? Other factors contributing to cardiac risk are our BMI, or weight to height ratio, okay, our blood pressure, and our smoking habits. Because smoking increases all of this and makes it a lot worse. Your blood pressure being really, really high is going to increase your chance of a heart attack, or stroke. And the shorter you are and the bigger around you are, the more you weigh and the more of your body is made up of fat and not muscle, the higher chances you are of a cardiac risk. So here's another one of our little activities, right? So we have Harry Warner was an alcoholic who had a heart attack 3 years ago. In a routine trip to the doctor, a lipid panel was run. The total cholesterol was 250 milligrams per deciliter. The HDL was 43. The LDL was 123, and the triglycerides was 157. If the test had been sent to a reference lab, how should the blood have been drawn? If the test was performed in the physician's office lab, how should the blood have been drawn? You guys pause these as these questions come up and see if you're getting the correct answer. So we're still talking about clear wave chemistry testing. So are blood chemistry tests quantitative or qualitative tests? Quantitative, okay? Is the fecal occult blood test quantitative or qualitative? It's qualitative, right? And we understand that quantitative is going to give us an answer. It's going to give us an answer that our total cholesterol is 200 or 243, right? That's an exact answer. That's a number, quantity, quantitative test. The fecal occult blood test, you're going to have that specimen on there, little piece of fecal matter, right? And then you're going to drop some reagent onto it and you're going to look for a color change. It's not going to give you a number. It's just going to tell you it's positive for occult blood or it's negative for occult blood based on me seeing a color change. So that's the difference between a quantitative answer and a qualitative answer. So principles of photometer and spectrophotometers, okay? So how do they work? They measure the amount of color change caused by the reaction of the analyte being tested, such as glucose or lipids, with the test reagents, okay? The color change is measured directly by light passing through the specimen called a transmitting photometer, or indirect light by light absorbed by or reflected off the specimen called absorbance or reflectance photometry. Okay? An example of transmitting photometry is the lipid profile or the Cholesterol instrument. So make sure you know that the Cholesterol instrument is transmittance photometry and that the AccuCheck is reflectance photometry, right? Because this question will be on a test. It will ask you to give an example of each one of these types of photometry. So what is the Beer-Lambert law? Okay? It states that the amount of color change is directly proportional to the amount of analyte within the specimen. So make sure you know that the concentration of a solution is directly proportional to the amount of light absorbed by the solution. So you want to be able to describe how the path of light works its way through a photometer, okay? Light passes from the light source we see in the picture, right, through a slit to a wavelength selector or filter, which produces monochromatic light, or light of one wavelength. Then the light passes through the patient's sample, the amount of light is detected by the photodetector, and then the amount is measured on the gravimeter. We want to be able to describe the quality assurance is used with optical chemistry instruments, because as we know, before we do any testing of a patient, like if we were doing a hematocrit test in the lab, we would always either check to make sure QC had already been run today, because it needs to be run once every 8 hours, 2 levels of control, right? We also have to do optic checks and or calibration checks on our instruments. Just like when you guys come in and check to make sure the freezer temperature is correct, the refrigerator temperature is correct, the incubator temperature is correct, we also want to do optic checks and calibration checks. We also want to run them and log them to ensure that the instrument is working properly with the reagent. And as I said, QC is run every 8 hours each day of patient testing. 2 levels of liquid control of a known value are run, logged, and analyzed to ensure testing results are accurate. Expiration dates and storage temperatures for testing supplies are checked and recorded, and current package inserts for controls and supplies are retained for reference. You will have policy and procedures manuals in your lab that also have the current package inserts for all the controls you're using and for any other things that you're using, supplies that you're using in your lab, like your kits. And when you get new kits or new controls in, you take the old package inserts out and replace them with the new ones. So here's one of our case studies. So you guys pause this, read through these, and make sure you're getting them correct. Okay, guys, if you're having any questions or concerns with any of these things that are on these slides, never hesitate to reach out. Text me, email me, call me, or make yourself a little note right now as you're going through these on any questions you have, and when I see you in lab, we can talk about it, okay? So we're still talking about CLIA wave testing, and let's talk about glucose testing, okay? There are many different brands of glucometers. That's instruments that test glucose, right? So what is the name of the CLIA wave glucometer we use at BIPSI? And what type of samples should be collected? Do liquid controls have to be tested, logged, and analyzed? And does an optics check have to be run and logged? So the first thing is we use the contour. It uses capillary blood from a finger stick. We do have to run liquid controls on it, 2 levels of control every 8 hours, and we do have to perform some type of checks on those instruments to make sure they're working properly. So now we're talking about what's the CLIA wave instrument used to do hemoglobin A1Cs, what type of samples should be collected, and do we have to run controls, and do we have to do any optic checks? At BIPSI, we use the DECA 2000. It's capillary blood from a finger stick is used, and yes, as always, you want to run 2 levels of liquid controls. Make sure they come in range. If not, you need to troubleshoot it, rerun it, and troubleshoot it until you get the correct answer, or you cannot use that instrument on your patients. And you always want to perform all your maintenance and optic checks on all your instrument and keep up-to-date logs on the fact that it's being done. So we want to be able to name the CLIA wave glucose test, right? We know we have fasting glucose, random glucose, we have an oral glucose tolerance test or a 2-hour postprandial. We have a glucose tolerance test and a glycosylated hemoglobin, which is a hemoglobin A1C. Make sure you're familiar with each and every one of these CLIA wave glucose tests. So our lipid profiles with the Cholestex, right? We know that we use at BIPSI the Cholestex LDX. It uses capillary blood from a finger stick. We always run glucose controls on our instruments, 2 levels of controls, 8 hours of shift when you're doing patient testing, and we always do all optic checks, coding, and maintenance on our instruments, and we're up to date on all that, and it is written down before we test our patients. So here's one of our higher learning activities, right? You want to tell which of the following are glucose tests or lipid tests. So you guys pause this and go down each one of these tests and see if you're getting the correct answer. So we understand postprandial tests, right? Glucose, total cholesterol, lipid, right? HDL, lipid, GTT, glucose, right? TC-HDL ratio, lipid, right? Hemoglobin A1C, glucose, right? LDL and triglycerides, both lipids. Guys, this will be on a test. You need to understand what value indicates diabetes for each of the following tests. Make sure you understand this and you get this, go over and over it so you can lock it into your brain. It's vitally important as a medical assistant or a lab assistant that if you're working in a physician's office lab, you will be able to immediately spot a test result that is out of control, and you will know that these are ones that we look for so that our physician we can bring it to their attention that this one was out of range, and this is indicating that our patient has diabetes. Again, You guys either going to be on a test. You need to know them. If you want to be the best healthcare worker and professional you can be as a medical assistant or lab assistant, you need to start memorizing these normal values. So now let's go on and talk about fecal occult blood testing, right? This is when we suspect our patient may have possibly a bleeding ulcer or something, and although we don't see the blood in our stool specimens, we suspect there may be blood there. Okay, well, we want to talk about the principle. We talked about this earlier, right? It's a qualitative test for the presence of blood that may not be visible to the naked eye, which that means it's occult, right? In a stool specimen. And you see, this is the little kit. We open up the back of it and we use those wooden applicator sticks to take a sample of our feces and put it on there. Then we close it down. There's filter on the part that separates from the top to the specimen, and then you drop a reagent down at the bottom, and that's your controls. You see those little orange squares down at the bottom, and then you drop them, and if it turns that real bright blue color, then it's positive for hidden blood. If it doesn't, it's not. You always want to make sure those internal controls work properly, or you have to repeat it. So what preparation will we have our patient on before they have this done? The patient should be instructed to follow a special diet prior to the test avoiding things like red meat, turnips, horseradish, bananas, non-steroidal drugs such as inflammatory drugs, aspirin and iron, and anticoagulants such as Coumadin or warfarin. So you're always going to go with the policy and procedures for your particular physician's office, and your physician is going to dictate to you what diet they want them to avoid. We want to avoid anything that may give us a false positive on the red, and anything that may cause some minor bleeding before the test is done. So how should you instruct, as a medical assistant, how should you instruct the patient to collect the specimen? So they need 3 consecutive stool samples should be collected using 2 different spots on the stool. Okay? A positive test is indicated by that blue water-like mark around the stool specimen after that developer reagent is added. Here's another one of our higher learning activities, okay? So I want you guys to read through this, pause it, and see if you're putting this stuff together. Okay, talking about metabolic panels. We remember, because we took that panels and profiles test, right? A panel or profile is just a group of related tests, like they're already related to our lipid, right? We were trying to see if we're at a risk for a heart attack. Or is our thyroid working? So we have a thyroid profile, right? Or are we worried how our kidneys are working? So we have a renal profile, a liver panel, right? So most panels are not CLIA wave tests, and blood must be drawn in a red, green, or SST and sent to either a big reference lab or over to our bigger labs inside our health system, right? We understand that electrolyte panel tests the measures positively charged cations and negatively charged ions like sodium, potassium, chloride, and carbon dioxide, right? We know that our renal panel is made up of that electrolyte panel, right? Sodium, potassium, chloride, and bicarbonate, but also albumin, calcium, creatinine, glucose, BUN, and phosphorus. We learned all these when we were learning our profiles and panels. And make sure you guys are still going over this, because a lot of this may end up on a registry exam that you have to take. So make sure you understand the test on the chemistry panel. Electrolyte right off the bat, right? And then we change that phosphorus to alkaline phosphatase, and then we add in the ALT, AST, total bilirubin, total protein. And then hepatic panel or liver panel is the bilirubin, the albumin, the GGT, ALP, AST, ALT, and LDH, right? A cardiac panel, a thyroid panel. These are all just groups of tests that doctors can use to see if our liver is having issues, if we've had a heart attack, if we're at a high risk of a heart attack, if our thyroid is working. It's just a good way for them to group tests together that give them answers to diagnose, monitor, and treat their patients for certain issues. So here's those key terms again. Remember, these are going to be on the test. Not only that, guys, you've got to understand what these words mean, right? So that you can use them effectively and you can speak intelligently to your coworkers. So make sure you go through these. I'm going to go through them quickly, but you guys can pause them, rewind them, look at them again. Use these as a way to study. Okay, so this finishes up chapter 6. In this chapter, we talked about that plasma components in the blood, right? That makeup, that flow chart, the proper specimen collection for chemistry tests versus a reference lab to a physician's office lab. We talked about the basic principles of glucose and fat metabolism. We talked about glucose, hemoglobin A1Cs, our lipid panel, our fecal occult blood, and CLIA wave testing. We talked about that Beer-Lambert's law and photometry, and we talked about tests included in different chemistry panels. Okay, guys, I'm going to go through a couple of these slides for you because these are a review. Okay, guys, use these reviews as a way to study and test yourself to see if you're getting these right, right? Okay, guys, so I'm going to, chapter 6 is up, and so then what I'm going to do is I will have your next chapter up soon after this, because remember, so test 5 is going to be on this chapter, chapter 6, which is on chemistry, and then I will be putting up chapter 7, immunology, this week. So remember, that test will be here before you know it. So as soon as you guys finish taking test 4, which is on chapter 5, hematology, mark that off your tentative course calendar. This week, quiz number 4, that little 10-point quiz on immunology and microbiology for lab will be up. You mark that off your list. Then you can start watching this one, filling out your review guides, and then when chapter 7 PowerPoints comes up, you can do it. So remember, this will be, when you finish test 4, and then you start studying for test 5. Remember, test 5 on chapter 6 and 7 will be the last regular test we have. I will put up PowerPoints for chapter 8. But however, there will be no final test on chapter 8, but you will be responsible for the material because there will be some questions on the comprehensive lecture final dealing with chapter 8. You guys have a great day.